right. So hi there, Cameron. How are you?
Hello, everyone. Welcome to this Dermpath Jeopardy. I would like to say a huge thank you to Karen. She's been absolutely amazing setting up this brilliant presentation. This is our second attempt at this because we primarily had a few technical issues the first time around. I always considered myself to be quite technologically savvy, but apparently I'm not. So that's okay. I've come to that realization, but it's fine. This is how we learn. I think the primary aim for this is to really help facilitate our understanding of cytology in private practice. It's always been a passion of myself, Andrew, and Heidi to grow dermatology in South Africa, and obviously just to improve the overall standard at which we practice dermatology. I'm not sure if you know, Karen, but we don't actually have any dermatologists in South Africa. So a lot of the dermatology that's done is actually done under medicine specialists.
Okay.
So we don't necessarily have a derms focused clinician registered in South Africa at present. So yeah, I think it is something that needs a lot of growth. I think our vets generally do a fantastic job at their dermatology. And I think the great thing about the Facebook page, and certainly your Facebook page, is that the more we share our knowledge and our passion, the more we grow. And I think what's great about specialists like Karen is that they give up their time in their very busy schedule to share their wisdom and pearls of amazingness. And we certainly are very grateful to Karen. And this is an absolutely fantastic presentation. And I certainly hope that you enjoy it.
Thank you so much for the warm and generous and kind introduction. Just for you folks watching, this is going to be a little mini version of the original talk. Just to give you a little taster of what it's like. The original was quite long. So we're just going to go through Jeopardy, and we're just going to play one of each category, just so you can get a little flavor of what it is. And as Cameron noted, we will try to focus on the cytology aspects. So let's get started with our game. The way I've structured this is I've divided it into 6 categories. Normally in Jeopardy, there's different categories and then different levels of difficulty for the questions in each category, if you're not familiar with that. And we're just going to do one from each of the 6 categories. So I've kept it simple in case you're looking on a small screen. I've labeled the categories A through F, and A is for alopecia. B is breed specific, C is for cytology, D is dermal masses, E is exotics, and F is feline. So I've just picked a random selection from the ones that we went through, and let's get started. So our first category up is A for alopecia, and this is alopecia for 500. So what we're looking at here is a dog with bilaterally symmetrical alopecia on the face. The lesion is concentrated primarily in the periocular area. You can see hair loss in the preauricular area, but it preferentially affects the face. So I've listed some differentials at the bottom for you to choose from, because I know it can be a little bit hard with the technology to do this completely interactively, but if you're playing along at home, these are some differentials. So see if you can guess what this condition is. A, alopecia areata. B, demodicosis. C, black hair follicular dysplasia. Or D, canine Sertoli cell tumor associated skin disease. So the answer for this one, and the way this works in Jeopardy, is the answer is always in the form of a question, what or who is, whatever. So it's, what is alopecia areata? So this is a very classic clinical presentation for this lesion. There may not be a whole lot that you would find on cytology in particular, the way you might find for demodicosis, but certainly it would be worthwhile to do your skin scrape and You could do a hair pluck as well if you're concerned about color dilution or black hair follicular dysplasia, depending on the appearance of the patient you have before you. If you had black hair follicular dysplasia, you could do a trichogram and look for clumping of the melanin granules within the hair shafts and look for breakage there. But really for this particular diagnosis, certainly the clinical appearance is so very characteristic, but also biopsy is a great option. So I would recommend from a Dermpath perspective, taking at least 3 skin punch biopsies. Try to aim for ones that are at least 4, but preferably 6 or 8 millimeters diameter. I would recommend taking it from the areas most affected. And what I would recommend is drawing a line in permanent marker or Sharpie to denote the normal direction of hair growth. The reason I suggest that, you can draw it right on the dog's skin before and then center your punch tool right over that line. The reason I recommend that is because then once that sample is submitted to the lab, the folks in the lab will know to bisect the punch right along that line that's drawn on the surface of the skin, and you'll get absolutely perfectly oriented sections, because what the pathologist is looking for on these samples is they're looking for the antigen hair bulbs. Those are what are targeted by alopecia areata. It's called classically a swarm of bees, and it's lymphocytic or a mix of different types of inflammatory cells, but predominantly lymphocytic, and it usually affects the hair bulbs and can cause some pigmentary incontinence. So that's the take-home message for this condition.
Out of curiosity, which breed do you predominantly see? Because I think, I mean, in the literature, it seems to suggest that Dachshunds have a predisposition. So just out of curiosity, which ones do you see most commonly?
That's a really excellent question. I can't say that I've personally seen or noticed off the top of my head a predisposition. So that's very interesting that you bring that up. I've seen it in several German Shepherd dogs and mixed breed dogs, but I will have to pay closer attention and go back through my records and look to see if I can find that specifically in Dachshunds. Certainly Dachshunds I know will get, what do you call the breed specific alopecia. It'll affect the pinna and the top of the head. I'm drawing a complete blank on that right now. I'm sure it'll come to me later. But they will get a certain type of alopecia that is, pattern baldness is what the Dachshunds will get. And certainly that can affect the head. So that will cause miniaturization of the hair follicles on biopsy. That's an excellent question. Thanks very much for bringing that one up. All right, so our next topic, breed specific for 200. So just to get you oriented here, we're looking at a German Shepherd dog, and we're looking at these large ulcerative type areas with extensive alopecia. They're oozing, they're very moist and wet, a lot of exudate typically associated with these lesions. Tends to affect the caudal portion of the dog, so the inguinal area, the caudal and lateral hips and thighs, the caudal lateral flank area, thoracic area. That's where the lesions tend to be concentrated, but of course not every dog reads the textbook. So I've listed some possible differentials here. A, German Shepherd dog pyoderma. B, familial cutaneous vasculopathy of German Shepherd dogs. C, metatarsal fistulation of the German Shepherd dog. Or D, pyoderma gangrenosum. Sorry, that one's a bit of a mouthful. So this is, what is German Shepherd dog pyoderma? So this is a very classic condition in German Shepherd dogs. Unfortunately, it can be very painful for them. And cytology, I imagine you would see a lot of mixed inflammation, perhaps a mix of pyogranulomatous. You probably see a lot of hemorrhage associated with it. You might see some bacteria on your impression smears if you were to collect those. This one, though, I think cytology is somewhat non-specific. And any clinical pathologists or clinicians, if you have a different experience with that, please do share that with me or let me know. This does have a very particular appearance though on biopsy, so I am a little bit biased in that sense. So for biopsies, I recommend collecting samples at the junction of the intact skin and the ulcerated areas, these areas that are very necrotic. And what you're going to be looking for, and be sure to let your pathologist or dermatopathologist know that this is from a German Shepherd dog. This also occurs in crossbreeds. So if it's a German Shepherd mix, I've seen this. And every once in a blue moon, we see it in dogs, or at least lesions that look very, very similar in non-German Shepherds, but that is exceedingly rare. But what we're looking for on the biopsies, again, I would recommend taking at least 3 samples. But the classic finding that you'll see are hemorrhagic bullae beneath the surface of the skin in the superficial to mid portion of the dermis. And they are gigantic, boggy areas of hemorrhage that are filled within the skin. You'll see some furunculosis as well. These lesions can be very painful for the dogs. And it's thought to be due to breed specific deficiency. And I think, Cameron, you had some more information on that, didn't you? About the details of this immunoglobulin type deficiency or something.
Yeah, so generally, I mean, as far as I understand, German Shepherds obviously suffer from IgA mucosal deficiency, which I think does predispose them to sort of, certainly from a dermatological point of view, pyoderma and gastrointestinal disorders and so forth. I think that does certainly disrupt the sort of dysbiosis on the skin, and that obviously then does result in sort of secondary infections and so forth.
Thanks. And what's your opinion on the cytology for these? Do you find that anything specific, or is it somewhat generic pyoderma? What's been your experience?
Somewhat generic, because often you find there's obviously a lot of secondary invaders. So it's very non-specific from that point of view. And I think given the breed and location, it is somewhat pathognomonic, and I don't think it's not your go-to first thing. I mean, obviously it is for in terms of identification of contaminants, but I think once you see it in a German Shepherd, you pretty much know what you're dealing with.
That's actually a really good point. Yes, I've noticed sometimes some of these conditions, if you haven't seen it before, the first step might be biopsy. But if you have seen this and this is on your list of differentials, you can sort of jump right in and go with treating for German Shepherd dog pyoderma.
But having said that, I think you always have to keep an open mind no matter what you're dealing with. Otherwise, that's how you get into trouble. So yeah.
Excellent point. Yes. Yeah. But certainly, yeah, that could move right to the top of your list. So if you had to prioritize maybe cytology over biopsy, you might go with biopsy if funds are tight. So what are your thoughts, or maybe even culture?
Yeah, I mean, I think it also comes down to what the owner can afford as well. And I think biopsy always remains the gold standard. And certainly unless you're concerned about, other non-specific sort of stuff. I mean, I think culture and sort of sellotape test should always remain your first line. And if that's obviously negative, then certainly biopsy would be a reasonable go-to.
All right, thank you. Okay, so moving right along, we'll go into cytology, and this is the cytology category for 400. So just to get you oriented here, what we're looking at are all of these rounded up cells, and then they have a nucleus. And then what we're also looking at are sheets of neutrophils interspersed with them. And these neutrophils, I just want to draw your attention to the fact that they are pretty well preserved. We're not seeing a lot of streaming chromatin or nuclear debris. So these are pretty well intact neutrophils. And so that's a key feature to pay attention to when you're looking at cytology for this condition. So if you were to see a cytology of this, of course, probably in real life, you would know if this came from a mouse or not. But just to see sort of a spot diagnosis, if you saw this in a post or just on the scope, you happen to walk by and take a look in the microscope and see this. A, would you consider plasma cells? B, histiocytes? C, apoptotic keratinocytes? Or D, acantholytic keratinocytes? So these are what are acantholytic keratinocytes. So these are the classic cell types and the hallmark feature that we look for when trying to make a diagnosis of pemphigus foliaceus. And so oftentimes we will see something to this degree, maybe not this extreme with this many acantholytic keratinocytes on cytology. This, of course, is the dream. But there are a few other differentials to consider when you see this. So if you have a dog with crusting lesions, there are some other possibilities, especially if there are pustules involved. So the three most common causes of acantholytic keratinocytes in cats and dogs, but particularly in dogs, are, of course, pemphigus foliaceus. You can have a bacterial pyoderma that can be severe enough to cause pemphigus and pyoderma, or just pyoderma. It can cause acantholytic keratinocytes, but those tend to occur in lower numbers, and the neutrophils would show more evidence of degenerative changes. And then the third differential, whenever you see acantholytic keratinocytes on your cytology, would be pustular dermatophytosis. So that's a pustular form of ringworm. The organisms, the hyphae with dermatophytosis, pustular dermatophytosis, can often be extremely rare and hard to find. But with both of those other causes, with both infectious, with pyoderma or dermatophytosis, the numbers of acantholytic keratinocytes will be far fewer, and you would expect to see more degenerative changes in the neutrophils. However, there are always those oddball cases of pemphigus that are complicated by secondary bacterial pyoderma. So always something to pay attention to. So I do personally recommend submitting some biopsy of intact pustules as well, if that's on your differential list, but also pay attention to the clinical signs that you have before you on the dog. If you're looking at a dog, look for any hyperkeratosis of the paw pads. If you've got lesions on a cat, classically, the three most common places you'll find involved with pemphigus foliaceus in a cat will be crusting of the pinna. You'll see crusting around the nipples, on the ventral abdomen and thorax. And then you'll also see some sort of a cheesy or exudative type lesion around the ungual folds, the nail beds in cats. So that would help to raise your index of suspicion if you're on the right track and you suspect pemphigus. So then moving along, we've got dermal masses for 300. So just to get you oriented here, we're looking at the distal limb just above the paw here on a dog. We're looking at a cluster of these finger-like projections. These are hairless structures. They are non-painful to the dog. They were just found incidentally. And so I've listed some differentials that you might consider for this. A, acrocortinous plaque. B, papilloma. C, inflamed linear nevus. Or D, colloidal fibroma. And this is an acrocortinous plaque. These occur most commonly. I see them in your bully type breeds, French bulldogs, English bulldogs. Any dog that has a lot of excess skin over the dorsal neck and shoulder area is probably where I see them most commonly, but they're still a fairly rare lesion overall. And they can technically occur anywhere, just like a skin tag might, anywhere on the haired skin. And these tend to occur in clusters, and there are these fimbriae, finger-like projections. And if you were to just biopsy one of them, it would be a skin tag or acrocordon. But when you get a cluster of them, it's referred to as an acrocortinous plaque. Cytology tends to be unrewarding for these because just like a skin tag, the bulk of these is just collagenous stroma, perhaps a little bit of fibrovascular stroma, perhaps a touch of that, maybe a little bit of epidermal hyperplasia on the surface. But usually these are unexciting to examine cytologically. They're typically uninflamed, although you could get a touch of superficial inflammation, but usually they will have a history of not causing the dog any issues, and the owner just happens to notice them, and they're considered incidental or perhaps a cosmetic lesion. So this is just a good one to be familiar with. And to my knowledge, there's no reported descriptions in the literature, and none that I've seen in my experience or from any of my colleagues of these ever undergoing malignant progression. So that brings us to exotics for 500. And so what we're looking at here are some pictures of very sad foxes with really extensive and extremely dramatic crusting, particularly along the margins of the pinna, all around the face, periocular area, affecting the entire body. So I've listed some differential diagnoses here. A, urticaria pigmentosa. B, I was feeling a little silly, Les Miserables. C, sebaceous adenitis, or D, Sarcoptes scabiei. So this is sarcoptic mange or sarcoptic scabies. And this is a very serious lesion in wildlife. It's not just foxes. It can affect many different types of animals, squirrels, bears, all sorts of coyotes. And certainly this is zoonotic and can affect people and of course dogs as well. But it causes extensive and very dramatic crusting lesions. And if severe enough or untreated for long enough, it can cause death in these animals. Cameron, was there anything you wanted to add for this? I think you had some other great differentials for this.
Yeah, I mean, Sarcoptes is generally very itchy as well. And I think that's probably one of the biggest sort of, clinical signs associated with it. And if you just look at the distribution, I think something like dermaticosis would also be on the differential list.
Mm-hmm. Excellent point. Yes. So with either one of those, I guess dermaticosis or Sarcoptes, you could do a scrape, and I would imagine that would show up well in cytology for the most part if lesions were this severe.
Well, I think Sarcoptes, you generally do a sellotape test, and that sellotape test will then, hopefully bring up the little parasites. And I think with Demodex, deep scrape is always the go-to, but sometimes, I mean, in this sort of severity, you would hope that you would see something, but sometimes you don't always see something, specifically those that are localized to the digits. Sometimes the only way you actually diagnose it is on biopsy.
Yes, you can diagnose it on biopsy, depending though how severe it is. Don't always find either the Demodex or Sarcoptes. Sarcoptes in particular, though, is unique on histopath. It creates extensive parakeratosis. So that's different from the orthokeratosis, where there's loss of, which is the normal type of hyperkeratosis or keratin formation, where there's loss of the nuclei, but the parakeratosis, the nuclei are retained in that stratum corneum. And the sarcoptic mites create tunnels on the surface that they burrow through, and you'll find the organisms and the eggs traveling through those on the surface. And that's something that's unique. And it's so interesting you mentioned about the Demodex. I came across an article. I can post it below once we share this. But something that I've been learning from some of the dermatologists and clinicians is that some of them are moving more towards the acetate tape prep for the Demodex, where they pinch and squeeze the skin and then use tape rather than the scraping technique, because I cannot count how many times I've had biopsies where they've suspected Demodex and they've done a scrape and we're not able to find the Demodex, but sure enough, they were there. So there is some thought. There's some recent paper, and I'll find that abstract for you. That they compared the tape technique for the Demodex versus the skin scrape, and they actually found them to be comparable. If not, the tape was slightly better. So I
That's
don't know.
interesting.
Yeah, yeah, I thought that was interesting too, because that was news to me. I think I came across that at a dermatology conference, and that was I thought very interesting. But I'm not familiar with that for scabies. So, all right, so that brings us to our last case, and this is feline for 400. So just to get you oriented, because this is a very close-up shot, this is courtesy of Dr. Loft at Angel Memorial, a dermatologist there. This lesion, I don't see a whole lot of photographs with this, and it's not all that common, but we're looking at a really tight close-up shot of the opening to the ear from a cat. And we're looking at this cluster of really darkly pigmented cystic fluid-filled structures. And I may have jumped ahead or put these out of order. I apologize. So the differentials that people usually have for these are melanoma, ceruminous stomatosis. Sometimes people will mistake these for being ticks, especially if it's an indoor-outdoor cat or one that spends a lot of time outdoors, or even hemangiosarcoma, because you can see how purple and slightly red the appearance of these are. So this is ceruminous stomatosis. It's thought to, even though it's rare, it's thought to be Abyssinians, Persians are thought to be perhaps overrepresented. And ceruminous glands are a modified type of apocrine gland. And apocrine stomatosis can also occur across the face or in the periocular regions, especially on Persian cats. Lesions just like this, but with a different distribution, mostly on the face. They're fluid filled. Cytology tends to be somewhat unrewarding. You might get a lot of fluid. You might get a rare epithelial lining cell, and those tend to be either cuboidal or attenuated. Very rarely are they tall cuboidal or columnar. Usually in these cases, they're pretty attenuated because they're stretched by all that fluid causing tension. And these are biopsy would be one way to diagnose it, but really just looking at it clinically, you can, there's almost nothing else that looks quite like this. It's a very distinctive appearing lesion. And cats that develop these, particularly in the ear, may be prone to developing all sorts of otitis issues because it obstructs the normal circulation of air within the ear.
Do you think these ever go on to become neoplastic in nature? Because obviously the chronic inflammation, you do wonder if that perpetuating irritation does sort of change the actual behavior of the allergy itself.
That's a really great question, and I don't know that I can answer that for sure. Certainly, about 50% of ear mass lesions in cats are ceruminous adenocarcinoma, and about 50% are ceruminous adenoma. And I do see quite a bit that are right on that line, right in that gray zone where they could be undergoing malignant transformation, particularly if I don't have a complete excisional sample and I just have little bits and pieces of it. I can't recall off the top of my head ever seeing this cystomatosis type of lesion ever undergoing malignant progression, but it could be that maybe we just haven't seen enough of these, or maybe we haven't paid close enough attention to that. So that's a really great point that you bring up, because that certainly could be possible. I know with apocrine stomatosis, which occurs primarily in dogs, in other areas, but again with the cats with the facial lesions, I've not seen that type of lesion ever undergo malignant transformation. But certainly some of them can develop multiple lesions, and they can just crop up in other parts of the body. With the apocrine stomatosis, at least in dogs, it tends to be more of a senile or degenerative type of change. And those can certainly, if they become traumatized, can become inflamed. So I think you're onto something there. If the inflammation causes the cycle, perhaps that could lead to something down the road. That's an excellent question.
But you just wonder, cats, specifically Persians, they tend to have a sort of certainly a genetic predisposition to catching ringworm, and you worry that if it's an immune suppressive type of
Yes.
anomaly, is there a link, and can that link move on to something a bit more nasty from that perspective?
That's a really good question. I don't know. I would be curious to know if there's any, like Morris Animal Foundation or Orthopedic Foundation for Animals, if there's any groups that study genetics in Persians. Because like you said, yeah, they get those dermatophytic pseudomystomas. I mean, if you see that on histopath, you can almost bet really good money it's from a Persian. Just because it's so rare in other breeds and species. That's a really good point.
I think these are quite nice. I mean, that these days they typically sort of excise them with lasers, and that seems to be quite a nice treatment option for these patients that sort of struggle with these conditions.
Okay. And did you say that they ever recur if you remove them a different way, or?
Well, that's always been sort of an anecdotal sort of take on it. I mean, I don't think that's necessarily proven per se. I certainly don't have any literature to back that up. But yeah, that's generally the sort of feeling that most people share with it. And I think the overall feeling is just to leave it,
Okay.
depending on what sort of severity it takes on.
Okay.
But I can't say I've dealt with many of these, to be quite frank.
Me neither, and certainly not clinically. So I would defer to your expertise. Yeah, I think there's still more to learn about these, just because I think they are somewhat infrequent compared to the other types of lesions we see. So that's everything. If anyone has any questions, I'm happy to answer them about this. And thank you so much for the generous invitation to share some of these fun cases with your group. I'm a big fan of the South Africa Vet Dermatology Interest Group, and anything I can do to support it, please let me know. Or if there's any follow-up or other questions, please reach out and I'll be happy to answer them.
Thank you very much, Karen. It's really been an absolute delight working with you. And I really hope that you'll be willing to come back and have another little webinar session with us again. Hopefully next time it'll go a bit smoother than did the last time.
Yes, and maybe, and we'd love to have you stop by the Vet Dermpath Forum as well and share some of your material. I think that would be fun.
Really, really a great platform for other people to visit as well. Karen does do Friday night sessions or Friday night sessions for us, rather, should I say, in South Africa. And she runs sort of a journal club and sort of presents really exciting cases. So if you have a particular interest, I would highly recommend visiting her page. Really, really interesting.
Thank you so much. Well, it's been a pleasure, and hopefully we'll meet again. Take care.
Brilliant. Bye.
Bye.